Good evening, everybody. I think it's okay to start now. It's 7:34, and other people can join in. Anyway, this is going to be live streamed and it's going to be available on YouTube, so people can always go back and watch it. Today, we have yet another important topic. We're going to talk on management of substance use disorders. And as you know, a lot of comorbidity with psychiatric disorders that makes a lot of difficulties in management would be substance abuse disorders. Very rightly so, management will take a precedence, and choice of drugs will actually be a very important armamentarium to discuss. We would like to thank Dr. Mohan Kumar for every program that he's doing, and he's really puts in a lot of effort for his slide. I really appreciate his motivation and his energy levels for making this class very lively. He
Thank
has
you.
just 2 more classes to go, and he's still available after the series also for any sort of discussions. And his email and all the contacts have been displayed in most of the programs. You can always get in touch with him. Today, he's going to spend the next 1 hour plus on talking on pharmacological approach to manage substance abuse disorders. Over to Dr. Mohan Sunil.
Thank you, Mahesh. Thanks for the opportunity. Um, so, I kind of have termed this topic as drug for drugs. Now, I'm sure as clinicians, we get a lot of people, especially family members, bringing their loved ones to our clinic and saying, "Sir, this person has been found to be using this substance," or they already know that he is into alcohol or any other substance for a long time. So they come and say, "Would you like to counsel him? Why don't you talk to him and make him stop the medicine?" Now, the challenge here is they believe when you talk to them, they might stop taking medicine. In the sense that they might stop using the substance. They believe that when you kind of tell them don't take the substance as a doctor, they believe that you might stop doing it. But in our routine clinical practice, I'm sure we know it is not as easy as that. It takes a lot of efforts. And most importantly, there are medications which are extremely helpful to kind of help through these people. Let me give an interesting example, which I quite commonly use in our clinical profile. And I've seen a lot of my patients understanding it very well. A lot of times they have depression symptoms. I might put them on some SSRI or sometimes even bupropion and those. They might ask me, "Sir, will this medicine be addictive?" I kind of, in a very simple way, tell them, "See, um, any substance or any behavior can turn out to be addictive in vulnerable population. But I would like to highlight to you an interesting point. This medicine, which is an SSRI or a bupropion mostly, I would say, is in fact, we use it as anti-addiction or medicine to treat addiction problems. So generally, we should not worry about addiction as a concern when we are prescribing this, is what I try to kind of put across. That gets them the point and makes them understand what they're doing. Because at the end of the day, as clinicians, we have great medications as tools, but we want medications to be followed regularly. We want people to be compliant. The best way we can make anybody compliant is to help them understand why they need medications. So going ahead, when you're talking about um, substance use, I'm going to keep it very simple, clean, and practical. We'll have a lot of interesting discussions on what kind of challenges happen. We'll try to understand the basic neuroscience about various aspects and all for us to kind of understand our own selves as well as to talk to our clients. I'm sure all of us have heard the term habit, right? It's so used loosely, left, right, and center. Most of us assume that when we say the word habit, each other knows the meaning of the word. In fact, it is the most confusing term, according to me, because until unless you exactly know what is a habit, you might assume the wrong things about a habit. So there are two terms which we all should be very familiar with. One is the term called impulsivity. Another one is the term called compulsivity. Impulsivity and compulsivity or compulsion are the two terms which we should understand. So, what does this impulsivity and compulsivity actually mean? When you're talking about impulsivity, it is like the key you put and start the engine, right? So whenever you sit in a car or a two-wheeler, what do? We put the engine, we put the key and start. that it starts, right? That is what impulsivity is linked with. What do I try to mean here? This impulsivity is linked with the ventral loop. The impulsivity is basically linked with the ventral or the anterior loop. Why is this important? Because it is basically linked with the ventral striatum, thalamus, and the ventromedial prefrontal cortex. So what are the three important areas in the ventral loop? The ventral striatum is there, the thalamus, and the ventromedial prefrontal cortex. That's what is linked with the impulsivity, and that's the ventral loop. So what is compulsivity or compulsion? Now, compulsion is little different from impulsivity. Impulsivity is more like a ignition or a starting of a motor activity. Compulsion is mostly, we're talking about a repetitive activity. It can be a motor activity, it can be a mental activity, but it's a repetitive kind of an activity. And this repetitive activity has lost its goal. We are doing it with no specific goal. We are not doing it for specific end result. We are just doing it without any control. That is component of compulsivity. And most importantly, it is very perseveratory in nature. Means what? We are repeating it despite any particular goal to be achieved. That's very classical of compulsion. Now, compulsion is linked with your dorsal loop. So impulsivity is linked with your ventral loop. Compulsivity or compulsion is linked with your dorsal loop. It is linked with the dorsal striatum instead of the ventral striatum. It is again linked with the thalamus, and it is more linked with the orbitofrontal cortex. Orbitofrontal cortex. So that's a basic understanding for us to know. The ventral loop and the dorsal loop is there. The ventral loop plays a role with impulsivity. Impulsivity, as I showed you just in the previous slide, it's like the key for ignition and starting the engine, right? The motor activity starts off with impulsivity, whereas compulsion is kind of a repeated action which might have lost its goal or it is perseveratory in nature. With this understanding, we need to know impulsivity and compulsivity could just be more like an endophenotype in a lot of us. And we all know when we are taking history of our patients, even though they would have come with substance use problems and those today, when you talk to them, as they have grown up, you would see that they have been quite impulsive or compulsive in nature. Especially impulsive behaviors are very common in a lot of people with substance use issues. I'm sure you would hear of hyperactivity issues, conduct issues, some of those things right being there right from a young age. They might not qualify for any of the diagnosis and treatment, but it is important for us to look at. They might have been endophenotypes which have been there. The impulsivity and compulsivity definitely can play a role. Now, we all say that human beings are a bunch of habits, right? We are all a bunch of habits. I have a few habits. You have a few habits. All of us are made of a bunch of few habits. Majority of the times, most of these habits are adaptive, so it doesn't cause problem. But some of these habits can turn out to be maladaptive and can lead to problem. But why do we become a bunch of habits? The reason we all become a bunch of habits is because when it is a habit, it is no more using the cortical structures of the brain. It's no more using the high metabolism structures of the brain. It is using the subcortical structures of the brain. So habit is something which is subcortical in nature. The reason brain chooses to get habit into our day-to-day routines is because brain as an organ is called to be cognitive miser. People in cognitive psychology say brain is a cognitive miser. Brain is very stingy to spend energy. So it does not want to spend energy. So it wants to just get automated processes. So that is why we are all a bunch of habits, not just our patients. We also are a bunch of habits. Most of the times, the habits could be adaptive, so we don't become sick. Whereas in our patients, we end up seeing some of their habits could turn out to become problems, and that's why they come to us to be addressed. Now, I did not still answer to you whether habit is a ventral loop or a dorsal loop or both of it. To make it very simple, I already mentioned to you, impulsivity is linked with the ventral loop and it is connected with the ventral striatum, thalamus, and the ventromedial prefrontal cortex. Whereas the dorsal loop is linked with the compulsivity or the compulsion process, which is linked with the dorsal striatum, thalamus, and the orbitofrontal cortex. So where does the word habit come? Habit is kind of a subtype of compulsion. In simple terms, habit is nothing but a subtype of compulsion or compulsivity. So it will obviously be somewhere in the dorsal loop. It is sitting in the dorsal loop and it is getting created in the dorsal loop. So when we say somebody has developed a habit, we are saying it's a kind of a subconscious process. We say the person is doing something, most probably not even looking at a particular goal or anything like that. And most importantly, we are saying some wirings have changed in their dorsal loop of their circuits in the neuroscience of the brain. So that's interesting point for us to understand. Most of the times, in simple terms, we need to understand addiction is a process of conversion of impulsivity to compulsivity. When do you say somebody is into addiction? When they are impulsive in nature, and slowly that impulsivity goes on, and leads to compulsion. That is what is the process of addiction. You would have seen a lot of youngsters, right? What happens is, for the first time, they would have gone to hostels, and some friend of them or some senior of them would say, why don't you drink alcohol or smoke weed? They have heard about it, they know about it to some extent, so they want to experiment. Because they want to experiment, what do? They go along with a friend for a party, so they drink or they use weed for the first time. Now that is experimenting. Now, once they've experimented a few times, what can happen is they might initially sometimes develop impulsivity. Like, for example, suddenly, let's imagine there is a little bit of discomfort, or they have had a very long lecture and boredom, and those sudden impulse can come that, okay, last time I smoked, I felt good, let me smoke up. So they might start with some impulsive processes, and as the impulsive behaviors go on, slowly they might progress to compulsive behaviors. When we see people in rehabilitation centers, inpatient cares, and those, most of the times, in most of your patients, they are no more enjoying the substance use. They actually are, in fact, they also want to stop the substance, but they might never be able to stop by themselves, and they are coming for professional help. So you need to understand. So impulsivity will progress to compulsion in many patients with addiction problems. So addiction is basically a combination of impulsive behaviors and compulsive behaviors which happens. This is where you also need to understand addiction is also linked with DLPFC. And what is DLPFC? The dorsolateral prefrontal cortex, right? The dorsolateral prefrontal cortex plays a role in executive functioning, cognitions, and those. If you see, in a lot of psychologists do CBT for patients with substance use disorders. Why do they consider doing CBT? They are trying to do work with their maladaptive cognitions in their head. A lot of alcohol patients keep relapsing. If you ask them why do they relapse, they want to take little alcohol and see whether they can control themselves. When they take that little alcohol, the alcohol hijacks their brain and they end up kind of losing control. So we need to somewhere change the maladaptive cognitive process in them and tell them, see, little might not work for you. So that's where CBT comes in a role, where they're trying to work with the DLPFC, the dorsolateral prefrontal cortex. That's the neuroscience behind the CBT processes, right? Now, in the same way, another structure in the brain which plays a role in addiction, especially, would be hippocampus and memory. Now, if you see a lot of them with substance use, one common pattern you will see is they chase the high. They would have had a very nice high, especially in the initial days of substance use. And they chase the high. They want to reach that same high. And in search of the high, they keep going towards it. They keep increasing the substance use and those things. Hippocampus can play a role in wanting to chase the high. And moreover, hippocampus can play a role in making people code all the paraphernalias and the friends and the same bar or the same restaurant or the same group or the same trip which they went. All those things get to be remembered. So whenever they have a similar experience, the craving kicks up. So you need to understand, addiction is not necessarily limited to one structure in the brain. Addiction is linked to multiple areas in the brain. So when substance use disorder progresses, you can assume that a lot of circuits go haywire in different areas of the brain, which leads to a significant brain disease. So addiction is called as a brain disease today, right? Or a brain condition. It's no more something of a willpower problem alone. So willpower and those things might contribute here and there, but you need to understand as a brain, the way brain functions in a person with addiction problem or significant substance use problem is very, very different. Amygdala does play a role, and that is exactly why, emotions, and a lot of times when they are extremely stressed or fearful, they end up smoking, drinking, and those things. So if you see a lot of your patients, you would realize one thing is they medicate themselves with the substance use. They are very anxious, so they take a substance which handles their anxiety. They have ADHD traits. Because of their ADHD traits, they want to treat themselves with substance use. So that is why, like Mahesh in his introduction, he told, right? Substance use problems are quite common, going to have comorbid conditions. You need to, in fact, understand, even before your substance use patients come to you for treatment, they would have tried to treat their own mental health problems with a lot of substances, which they would have lost control and got into addiction. In simple terms, if you're talking about addiction, you need to understand there could be a bottoms up and a tops down approach, right? So what you need to understand when you're talking about addiction, two problems can happen. The cortex down to the structures, the messages which comes from the cortex and down, from the DLPFC, dorsolateral prefrontal cortex, the ventromedial prefrontal cortex, the orbitofrontal cortex. The cortex is supposed to give jnana to the subcortical areas and say what's right and what's wrong. Imagine those structures don't function well. What will happen? They don't take right decision. That's a common problem which happens in addiction. And the green one is to remind you the bottoms up problem in addiction. What is the bottoms up problem in addiction? In patients with addiction who are genetically vulnerable, they have issues in their neural circuits. So the impulsivity could be very high, compulsivity could be very high, the subcortical structures could be hyperactive, which could lead them to have these urges and these kind of addictive behaviors, which leads them into substance use problems. So you can always kind of clinically look at what's the issue which is happening. Top down, what is the problem? Bottoms up, what is the problem? When you talk to patients in these terms and try to explain why they need help, whether it's therapy or medication, they many times understand much better and also cooperate for the treatment in a much more sensible way. That's an important point for us to learn here. The next point I would like to highlight here is, we all know this. So addiction is a brain condition. It has multiple factors which are involved, which leads to substance use disorder, which is significant. It is by definition a chronic condition and a relapsing condition. So if you expect your patients to get better just because you prescribed some medication, I think we are in a fantasy world. It doesn't happen majority of the times. Majority of the times, by rule, in addiction, you need to understand relapse is quite common. In fact, you should give permission to the patients or the clients you see and tell them, if you by chance slip, don't get worried. Please come back and meet us at the earliest. Don't allow it to advance to the last final stage. And don't feel the doctors will be angry. Don't feel the therapist will be upset. Please come and meet us. Take the right help. Get out of it at the earliest rather than allowing it to go ahead. So giving them the permission to come again and meet us when they have failed is an important tact to use in therapy, because it helps a lot of things to come back to us as clinicians and take it. Now, in the same way, you need to understand when you're talking about substance use disorders and addiction problems, it's compulsive, it is control is lost commonly, craving is quite commonly going to be seen. We'll touch upon craving and those in few slides further. There will be a lot of consequences which are happening, but despite the consequences, they will continue. If you remember on the slide where I discussed about compulsion, I said compulsion people, they would be doing things even though they would have lost any specific goals or any results they're looking for. That's very characteristic of them. Then why do you expect patients in substance use disorder to stop because they are already having liver cancer or lung cancer or health issue or financial problems? They might not stop it because by definition, if they are in compulsive behaviors, they might continue to do it until unless some interventions can be done and serious efforts can be done to help these people. and it's a chronic relapsing condition, right? So in simple terms, the genes can play its own role. The development of the brain itself is known to play a role, because we do know very commonly, along with the genetics, right? Brain's development, especially people who go through childhood trauma, whether it is physical trauma, sexual trauma, broken families, any of those things, they are all vulnerable populations, because a developing brain is known to have its own cracks. And when these kind of adverse experiences happen, it makes it more vulnerable for substance use and many other mental health conditions. Environment definitely can play a role. Now, why am I highlighting this is because you need to understand, neuroscientifically also, there are a lot of drawbacks in people. There are reasons why people might get into substance use problems. What is the natural drawback I am talking about? So if you take a simple gross structure of the brain, and this is the anterior and this is the posterior, superior and inferior, what you need to understand is the pink marking here is the PFC. What is PFC? Prefrontal cortex. Now, we all know prefrontal cortex plays a role in cognitions, thinking, executive functioning. So a lot of our decision-making systems are working in the prefrontal cortex, right? So the prefrontal cortex does that most important work for all of us. Now, this is sitting here in that part of the brain. What you need to know is, when you're talking about maturation of the brain, maturation of the brain starts from the posterior and then goes anterior. Also, maturation of the brain starts from the inferior, then goes superior. What does it tell? As the kids grow up, when they reach adolescence and young adults, their brain keeps maturing, and the brain maturity starts from posterior, comes to the anterior side, starts from inferior, goes to the superior side. So what happens to your prefrontal cortex? It is busy sitting in that corner, and it is almost kind of quite a late stage of maturation when prefrontal cortex will get matured. So why is this important? Till it gets matured, it remains very, very, very vulnerable. So that is exactly what we also see in our clinical practice, right? Lot of hardcore patients who are in significant advanced substance use problems, many a times are young onset users of substances. Like they are young onset users. Of course, there are a lot of people who start at a late age but advance significantly, but many times they might have a strong family history and they might have other comorbid conditions. It does happen. I'm not saying it doesn't happen, but please remember, when you're talking to adolescents, they are the most vulnerable population, not because they choose to smoke or choose to drink or something like that. Many a times they might not be able to take the right decisions, and that just adds up to the vulnerability and leads to problem. So this also helps you when you actually go and talk in some kind of communities like colleges and schools, where you're talking about a bunch of high school kids and young adolescents, right? It's important for you to say why biologically they are at a vulnerable point and they need to work on themselves. So talking in specific about addiction, there are some specific other interesting areas which have been noticed to have its points. If you look at the coronal section of the brain, there is an area of the brain called the septal area of the brain. Septum is the septa, the middle differentiating point, right? So septal region is a very interesting point, because if you stimulate the septal region in a rat, in anybody else, if you stimulate the septal region of the brain, they people are willing to get it stimulated for any cost. They've done studies in a lot of rats. What they've done is they've kept a bunch of food here, which will keep them alive. They have kept here a machine. If they press this machine or the lever, they get a septal stimulation. So they have seen the rats not going towards the food and willing to starve and die because they want to keep on stimulating the septal region. The septal region seems to be so important area, because if you are going to get that area stimulated, you're willing to compromise on anything. Why am I stressing this point is because we have seen a lot of family members coming along with the patient and they cry. They say, why is my husband or son or daughter or whoever it is not able to understand. We are all going through so much pain. Why does he not able to understand? Please understand, if unfortunately the wirings in their brain has kind of got stimulated in wrong areas and the circuits have got entangled in a different way, then they might continue to do it because they need some help. This is why sometimes you need to choose what kind of help will work. In some motivated people, outpatient care can easily work, whereas in people where they're finding it difficult to even keep themselves abstinent, it's a good idea for us to use good inpatient setups or rehabilitation setups where they can stay for a longer time, not because they're very sick, because if they want to seriously get better from their addiction problems, we need to get them away from the substance to even understand what is the kind of intervention you could do. So to evaluate your clients and understand what kind of help you want to give, it's important for us to know these neuroscience basis. We also know motivation and drive is an important issue in substance use conditions. The structures in the brain which play a role in motivation and drive is the orbitofrontal cortex, the anterior cingulate cortex, and the dorsal striatum. These three structures basically drive or motivate the person towards the substance, or if you can help these people, can also help them to regulate the substance usage. Because please understand, in general terms, almost 10% of the people who use the substance only get into addiction. Majority of them can be social drinkers. Majority of them might use substance occasionally and never get into addictive problems. So don't think all the people who start smoking will end up smoking. All people who drink will end up getting into addiction. Not necessarily. If they're vulnerable, yes, they are more prone, is what we need to understand. Glutamate is known to play a role in substance use disorder. One of the reasons is glutamate is an excitatory substance, right? So when learning is happening, glutamate is going to be released. Whether it is adaptive learning or maladaptive learning, it is the same glutamate which will be released. And the glutamate release also leads to long-term potentiation. Why is this long-term potentiation important? Is because sometimes studies have shown in a person with substance use disorder, the brain possibly remains vulnerable all their lifelong, even if they're stopped using substances actively. Even if they've stopped using substance for many, many years or even lifelong, they might remain vulnerable. This is extremely important to be educated, to put across to the patient, because they need to understand if they stop for 10 years, it doesn't mean they'll be completely free from it. They can still be vulnerable. So going into more details of the substance use pathways and those things, I've kept it very simple here. The most important structure I put up here is the pink one called the VTA. Okay, ventral tegmental area. VTA, the ventral tegmental area, if you take, has some connections which goes up to the prefrontal cortex, some connections which goes to the nucleus accumbens, some connections which goes to the amygdala, and some connections which goes to the hippocampus. Now, this is a very simple way for us to understand. Not necessarily this is the only pathways which are playing a role. So ventral tegmental area, one connection to the prefrontal cortex, which is called as the mesocortical pathway. The mesolimbic pathway is nothing but ventral tegmental area from the nucleus accumbens. You also have connections to the amygdala and the hippocampus. Now, why is this important for us to know? These pathways are also linked with various substances, right? Neurotransmitters. What neurotransmitters are we talking about? The dopamine, the GABA, and the serotonin pathways. Earlier in the same series, we spoke about GABA, dopamine, serotonin, how modulations happen. You can look at some of those past videos for you to learn a lot more about these neurotransmitters. An interesting point you should know is this ventral tegmental area gets some inputs also. The ventral tegmental area gets some inputs. From where does it get the input, by the way? It gets inputs from the subcortical attention system. Why am I stressing this point? I'm stressing this point is because you would have typically seen in a lot of your patients who are pretty much doing fine, they've stopped substance use, and one fine day, unfortunately, they would have started using the substance. And when you ask them, why did they relapse? They'll say, I was walking on the road, I saw a bar, I just thought I'll stop my vehicle and take a little bit. They started drinking and unfortunately, they slipped completely. Now, why would it happen? Please understand, if the person's brain already is vulnerable, and there are strong pathways which have got created, which have positively reinforced substance use over a period of time. And if he is abstinent for a brief time, the subcortical attention systems can send signals which is kind of going to tilt the balances. Have you seen one interesting thing which happens with a lot of alcohol patients, especially with alcohol and smoking people? Um, they would have stopped smoking or drinking, but they'll say, I wanted to see how much control I have, so I went along with my friends to the bar. I sat with them, but I did not drink. I wanted to see how much control I have. Now please understand, that's nice to see that they would have actually kind of controlled themselves, but it is a very daunting task they're giving to the brain. They are testing too much with their brain's resources, because you need to understand, when they do it, it's nice to hear that they could succeed, but the chances of they failing also remains high. So it's a good idea for us to say, instead of trying out such weird things by going and sitting in a bar and seeing whether they can control themselves, smoking, drinking and all, we say, just kind of avoid slippery situations and work on. A lot of 12-step processes talk about how to avoid slippery people, situations, and circumstances which can make them slip. So it's a good idea to talk to them and say how inputs from attention systems can give you some cues. If you see the same friend with whom you used to smoke or drink, it can give you a cue. If you see the paraphernalia, it can give you a cue. So talking to the clients and putting the neuroscience helps them to understand why we call it as a brain disease. Otherwise, it doesn't work. So a couple of neuropsych points here I would like to highlight, because even though we are psychiatrists, right, it's a good idea for us to understand what happens in the cognitive psychology components. It is just not about a high with the substance. A lot of times, in simple words, we say substance use problems is nothing but we get a high because of substance use, so that makes us continue the substance. But it is not just that. There are a lot of other interesting things which happen in the person's problem. So we need to look beyond the high. What should we look for? We need to look for prediction error. Now, I'll give you a simple example of what is prediction error. Instead of talking about an example of substance use, we need to understand the dopamine which is released in these circuits are released in large amounts, and it is released when prediction error happens. Let's take a gambling task. Okay, when somebody is gambling, right? A simple game, a head or tail, is a simple game of gamble, right? 50% chance that you'll get a head, 50% chance you get a tail. Now, the point here is, I'm telling tail 10 times, and every time you flip the coin, let's imagine it comes head, 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 continuously 10 times. So what happens to me is, I no more see that coin to be a rational coin with 50% chance. Something tells me, okay, 10 times it has come head. So I increase my bet and say, this time it will come as a tail. I'll put ₹1,00,000 on a bet, and I might fail. So prediction error is when you cannot predict, and suddenly when you get a high, imagine suddenly when I get that high, and imagine that time it turns out to be a tail and I get ₹1,00,000 immediately. Can you imagine the buzz which happens in the head? That prediction error is the thing which lays the foundation for substance use disorder. It is not just the high, it's a prediction error which happens. Why I'm stressing this point is because in a lot of people with behavioral addiction, you will see they get behaviorally addicted because of the prediction error. They cannot predict when it can happen. That makes them get addicted to various behaviors. Incentive salience. If you're talking about incentive salience, what is the common example we give to our patients when we are explaining? We say, instead of smoking, why don't you do one thing? If you're feeling stressed, why don't you go for a jog? We say, why don't you go for a gym? These days, COVID is kind of status is better. Gyms are getting opened. Why don't you go to gymming rather than smoking up cigarettes? Now, it looks very nice and a good alternative given to the person. Instead of smoking, go to the gym. It looks like pretty nice. Do you think that person mostly will follow that? We know most of the times our clients don't follow. Why? Because for this person, it's just not the high. Dopamine release codes the brain with something called as an incentive salience. It gives too much importance to the incentive, and salience means what? It gives importance to that incentive. So basically, it says the high which you had now with the substance, That's real high. That's the real pleasure you should look for. So they go in search of that, and that makes them use the substance use again and again and get into the trouble. And most of the times, we all know anticipation is more a high producing one rather than the result, right? Anticipation is extremely important. The anticipation, even as kids, they do, right? When they're opening the gift wrapper, they are so excited when they're opening the wrapper. The moment they see, okay, car, is it? Okay, the moment they see what is the gift, the whole excitement goes off. Now, this is what happens with a lot of people. Have you seen a lot of people who use weed and all? For them, clearing the cigarette, rolling another joint, that itself is a nice, soothing activity. I've seen one of my patients who actually recovered from his weed use. What he used to do is he used to still roll joints, but not used to put it in his mouth, because for him, he realized the high was the rolling of the joints more than even putting it in his mouth and smoking it up. So I think sometimes they find their own weird ways to kind of get out of the substance use. Now you can ask me, if he's rolling every now and then, would he not use it at some point of time? Luckily, to my knowledge, he followed up at least for 2 years after that. He kind of had rolled and given joints for many of his friends, had never spoke up according to him. So what I'm trying to give you an example here is anticipation, the kind of whole behaviors which happens even before the substance use, they all can lead to substance use disorder or addiction behavioral problems. So knowing about it can help. Hypothalamus has its own role to play. Now we know hypothalamus has a lot of drives and physiological functions taken care. Why is this important? Because you know when hypothalamus goes haywire because of stress, because of various other instincts and drives and long-standing stress and issues, you can have dysfunction of the hypothalamus. The hormonal changes can happen. The whole physiological changes can make people vulnerable to substance use problems. To keep it simple, what I want to highlight here is addiction, if you see, can start from simple mesolimbic dopamine issues to nucleus accumbens issues, the dorsal striatum being involved, the prefrontal systems being involved, the extended amygdala, hippocampus being involved. So if you basically see a problem from neurotransmitters goes on to multiple circuits to multiple areas of the brain. So this is why a lot of times forget about the patients who are concerned. Even doctors and professionals who work in this area sometimes carry a lot of therapeutic nihilism. We don't know what to do. We ourselves are quite negative about these outcomes. So we ourselves are quite demotivated about prescriptions or helping these clients and those things. In fact, I know of a lot of counselors in Bangalore who specifically say, don't refer me patients with substance use issues. I don't work with them. When I have one-to-one discussions with some of these very good counselors, they say, "No, I don't know how much of therapy can work." So there is a lot of therapeutic nihilism by the professionals itself. Forget about patients being demotivated to come. We should at least work on our motivation. That is the aim of my whole lecture here, where I'm trying to say how we can approach substance use in multiple ways. And substance use problems is a confluence of a lot of challenges. Confluence of what? Traits, endophenotypes, genetics, home environment, early experiences, awareness, availability, relationships issues, comorbidities, the whole treatment course, when they come and meet us, whether they follow the treatment procedures. So like that, if you see, addiction is a complex confluence of a lot of factors together. So all of us look for a high. All of us want a nice feeling, pleasurable feeling. All of us want some kind of a buzz in our head. But most of us are looking for natural highs or a relatively healthy high. But unfortunately, when we're talking about substance use disorders, the highs go haywire. When you're talking about natural highs, we need to understand there are substances in our brain which are already there, which can almost do what substances are available in the rave parties, and those cannabinoids are there, opioids are there, acetylcholine is there, which is equivalent to the nicotine outside, dopamine is very much there. So instead of going out, we need to understand there is a cocktail of drugs inside sitting in our brain already. So that is where the natural eyes work. But what happens in drugs of abuse? The drugs of abuse, when it is taken, it manipulates this natural eyes. The natural eyes manipulates the drugs of abuse. So ultimately, it gets into a big tussle. Now, I did mention a lot about dopamine. I also spoke to you about the dopamine kind of having link with incentive salience. Please remember, in simple terms, dopamine is linked with four important things. One, dopamine has as there is something called as a tonic firing and a phasic firing. What is a phasic firing? Phasic firing is very high frequency firing of the dopamine neurons. Now, this phasic firing is what is very important in substance use disorder. It leads to incentive salience, anticipation, and it also, that rate of increase, the speed at which the dopamine can increase says how addictive the substance can be. The speed at which dopamine can increase can say how addictive can substance be. I'll highlight this point through another slide in a few minutes time. When people stop the substance, we all know they go through a little discomfort phase or a dysphoric phase, irritability, anxious, depressed phase. Why does that happen basically? If you're talking about the neuroscience behind it or the neuropharmacology behind it, you need to understand lack of dopamine, lack of opioid, lack of serotonin, lack of GABA in some of these circuits, or increase in the CRF, norepinephrine, glutamate. They all seem to be the reasons for the dysphoric state which people get in. So these are some neuroscientific aspects which you need to know between what happens in substance use and the withdrawal states and those. So we'll try to get into three important substances we'll try to highlight. One is the cannabis or the weed we're talking about. One is the nicotine, other one is alcohol. There are a lot of other substances which I cannot touch upon, basically because one, it is seen in exclusive setups and those most commonly, and more importantly, that needs their own lectures separately. So we'll try to highlight most common ones here. Is about 80 to 90% is the amount of nicotinic receptors which get blocked by a single cigarette. I'm sure you know, if you've already worked with people with nicotine, out of the common substances of abuses, right? Nicotine is an extremely addictive substance, is what we know. Nicotine use is extremely addictive. And one of the reasons is its ability to go and work very quickly in the brain and work in multiple receptors with just one cigarette. So it goes very quick. In 15 seconds, if you have smoked a cigarette, in 15 seconds, it's sitting on the nicotinic receptors and talking to the nicotinic receptors, the nicotine. So that's the level at which it works. So that's one of the reasons why it's quite an addictive substance. In fact, one of the most commonest addictive substance we have. Next important point we need to understand is there is this, when you're talking about nicotine, if you would have already known about this alpha 4 beta 2 receptors, please remember, we'll come to this alpha 4 beta 2 receptors, but you need to understand the alpha 4 component plays a role in sensitivity, and the beta 2 component plays a role in behaviors of nicotine use. Okay, it is linked with the behaviors of the nicotine use, whereas the sensitivity is taken care by the alpha 4 receptors. Why this is also important, right? When I'm talking about sensitivity, we know each one of us are vulnerable very differently based on our genetics and other reasons. So that is exactly why it's a good point for you to know what could be the differences. So when you're talking about nicotine, you need to understand there are two specific receptors on which we are talking about nicotine. One is the alpha 7 receptors, where nicotinic receptors. Another one is the alpha 4 beta 2 subtype of receptors. These are the two main receptors which we are talking about when you're talking about nicotine use disorders. Alpha 7 and the alpha 4 beta 2 nicotinic receptors we are talking about. What you need to know here is alpha 4 beta 2 receptors are basically post-synaptic in the ventral tegmental area, and in the post-synaptic alpha 4 beta 2, it goes on to release more dopamine, and you know, more dopamine release in the nucleus accumbens leads to addictive behaviors because of the pleasure they get. When you're talking about the alpha 7 receptors, it is sitting in the presynaptic area, and it leads to increase in the glutamate, and it further on leads to increase in the dopamine in the nucleus accumbens area. So alpha 7 through glutamate increases dopamine in the nucleus accumbens area. Alpha 4 beta 2 through the postsynaptic receptors, that is the alpha 4 beta 2 receptors, it increases the dopamine in nucleus accumbens. One more important point you need to know is the same alpha 4 beta 2 receptors through the GABA disinhibition again leads to increase in dopamine. So if you wonder why somebody is addicted to smoking, they get addicted to smoking because because of the alpha 4 beta 2 receptors, through which dopamine is increased by the postsynaptic alpha 4 beta 2 receptors, or the GABA disinhibition, which leads to increase in dopamine. Another way is through the alpha 7 receptors. It increases the glutamate, and which ultimately leads to increase in dopamine in the nucleus accumbens area. Now, when you're talking about nicotine use, we need to understand a simple strategy we follow is nicotine supplementation, or we can deal with craving. When you're talking about craving, two commonly used substances are varenicline and bupropion. We'll come to it in just a few minutes' time. So when you're talking about substance use, especially nicotine use, right, you need to understand about 1/3 of smokers can quit just about 2 days. Just about 2 days they can quit. 1/3 of the smokers, they find it very difficult to quit more than 2 days easily. Only 3 to 5% of people, 3 to 5% of nicotine use disorder people can quit more than a year, 365 days straight. Okay, 3 to 5% of the can do it. Now, why should we professionally help them? Why should we give treatments and medications? Treatments of different nature, whether it is nicotine replacement therapy, craving reduction, what has been shown is the quit rates from 3 to 5% can be doubled or tripled by the use of professional intervention. So professional intervention seems to help a lot more people to quit nicotine, and we know nicotine is such a dangerous substance for medical conditions, and those it's worthwhile, even if it is just 2 times to 3 times, it's worthwhile to help these people and offer these people help. Now I'll be taking this question, so let us see which of the following graphs are possibly depicting smoking. Now, smoking of nicotine I'm talking about here. Which of the possible graphs is possibly depicting smoking? Whether the gray graph could be possibly depicting smoking. I'm asking the way in which the nicotine concentration in the brain is raising. The nicotine concentration in the brain is raising. Which graph out of this could be depicting the smoking of cigarettes? Nicotinic cigarettes, the red one, the gray one, the green one, or the blue one? What do you think is the answer? Shriram, please put up the choices for people to answer. Thank you. So which of these graphs is possibly depicting smoking? Is it the gray, green, red? Which one? I see most of you have already answered, and majority of them have chosen the choice 3, that is the gray one, possibly being the reason. 55% of them have chosen that. The least chosen one is the choice 4, that is the green one. In fact, if you see the red one, which is choice 1, about 33% of them have chosen the red one. Now, just a few minutes back, I told you when you smoke nicotine, within about 11 seconds to 15 seconds, right? Your brain is buzzing with nicotine. Your brain is buzzing with nicotine within about 11 to 15 seconds. So that means the nicotinic concentration in these receptors would just go skyrocket the moment they use nicotine. So what do you think is the answer then? The answer obviously would be the gray graph. The gray graph would be a better choice here rather than anything else. Now, why have I chosen this particular graph is because what do you think is the red one depicting here? Now, have you heard of nicotine patches, by the way? Nicotine patches we use, right? Now, nicotine patches, kind of is going to give a constant delivery of nicotine over a period of time. It's not going to give a high, low. It will constantly give nicotine over a period of time. You can have a 21 mg patch. You can have a 14 mg patch. You can have a 7 mg patch. Very few companies have these patches. The Indian companies now out there have the cost much lesser, more affordable. Earlier, it was very difficult to get these things. So the red graph is basically a sustained nicotine which is being given, which is typical of a nicotine patch, which is very, very useful. The advantage of a nicotine patch is it is user friendly. They can put a patch in the morning. Next day morning, when they want to go for bath, they remove the patch and put the next patch and start using it. It's self-explanatory. The boxes will have a small description about how to put an image and those things. They follow that, it's taken care. Many a times we see no side effects with it. Very few people come and complain about some irritation when they're using the patch, and some of them say worsening of anxiety, nausea, and sleep disturbance when they're using the patch. One of the strategies which is told to people, especially if there are too much of sleep problems, is to remove the patch before they go to sleep. Not necessary is what we have seen, but in some people we have seen it beneficial if insomnia is one of the challenges they feel. Otherwise, if they're doing fine with the patch, you can consider that kind of a strategy to work in those people. Now, what about this blue and green color lines in this chart? Now, the blue and green color lines are typically more depictive of the lozenges and the gums which are available. Lozenges and the gums which are available. Now, why am I talking about lozenges and gums is because most of these times, if you see your clients who are coming and meeting you, they would have already tried a gum or a lozenges by themselves, especially gums, because if you go into many medical shops, in the front, along with all the Cadbury's and chocolates they have, one box mostly they would have kept is nicotine gums. They would have kept there. Now, a lot of we all know a lot of smokers want to quit smoking, so they go there, they want to buy a sheet of it, they try, and they mostly fail in it. And please understand, when you want to prescribe a gum, they're going to say, I tried the gums, it's not going to work. So it doesn't mean you should not prescribe a gum. In fact, you should ask them, how did they use it? Because there's a better way or a right way of using it. One of the very well-known strategies which is recommended, like if you look at tobacco cessation clinic and study materials, what Nimans has over years, they've always put up on chew and park method, which is something I've kind of always spoken to my clients when they use gum. I always spend a minute telling them how exactly they should use a gum. For a simple reason is, please understand, when we chew nicotine, the juice which comes will have nicotine in it, right? If I swallow nicotine, it's a nauseating substance. And moreover, it's a gastric irritant. So it is going to produce nausea, it's going to produce gastric irritation, which basically means I'm not going to use nicotine gum if I swallow the juice. I should not be swallowing the juice. So what is the best way to use that? The best way to use is something called as a chew and park method. As the name says, you have to chew the gum and keep chewing the gum. As you're chewing the gum, once the juice is coming, it will cause a little bit of burning sensation or a tingling sensation in the inner mucosa, which means the concentration is getting better. So they park the gum in between the cheek and the teeth. In between the cheek and the teeth, they park it for some time, allow the juice to be absorbed through the mucosa. If they swallow, it causes problems. So we don't want them to swallow much. We want it to be absorbed as much as they can. So once they absorb, it reaches, gives decent amount of nicotine so that craving or withdrawal does not happen with the gum. So teaching the right method of using the gum is very useful. And a simple count you can remember is, if people are using less than 25 cigarettes, which is what majority of the people whom we see will have, you can recommend them to use about a 2 mg gum, 2 mg nicotine gum every 1 to 2 hours, depending on the need be. Every 1 to 2 hours, whenever they are awake, they can use 2 mg gum. If they're using more than 25 cigarettes, which is also a population we might end up seeing, but less commonly they might come to us. But those kind of population, you can actually give 4 mg gums, 1 to 2 hours every awake hour. Now, it's a good idea to continue it for about 12 weeks of time, and then taper and stop. These are things which we can do. We have extended it in some people over a period of time. I also can share one interesting scenario is literature doesn't talk to you about nicotine being gum being addictive and those things, but we also know nicotine gum does give nicotine, right? And I know of at least two of my patients who have been following up for a very long time, more than 4 5 years. They continue to use a few gums per day. But the thing here is, I still feel personally that's a relatively a better choice than smoking 4 to 5 cigarettes per day, because the amount of other impurities and other things which enter into their body might at least not be happening with their gums. Even though a lot of literature is not available on whether these things can cause it. In fact, a lot of them say why it might not be addictive, because you, as I showed you in the graph, the nicotine smoking is a significant straight uprise and then down, whereas the other ones are much more slower. So it should generally not cause addiction, but here and there you can have exceptions. You can have people who can come up and present to you like that. So for the first 6 weeks, you can give gums every 1 to 2 hours. Then 6 week to the 10th week, you can give 2 to 4 hours, and slowly taper down in the 10th to 12th week, every 4 to 8 hours. That's how you can deal with giving the gums and helping these people. Other than that, we also have a lot of anti-craving agents. One of the important anti-craving agents for nicotine we use is bupropion. Bupropion is known as an antidepressant, which is again used as anti-craving. Why is it an antidepressant? Basically because it blocks the dopamine transporters and the norepinephrine transporters. Thereby, it increases the dopamine levels and the norepinephrine levels. By increasing the dopamine and the norepinephrine levels, it helps people to get out of their depression. The same increase in dopamine is the theory by which you try to explain possible anti-cessation property with bupropion in smoking. But as psychiatrists, it's good to be aware that when we use bupropion, some of the challenges is it can be anxiogenic. It is one antidepressant which is known to worsen anxiety, especially when patients are given medication. When you start it, worsening of anxiety is quite a common challenge. Sleep issues are quite common. So it's always recommended to be given in the morning or the afternoon, not in the night, because it can worsen sleep issues significantly. Gastrointestinal disturbance, nausea, vomiting is one of the common reasons why we stop this medication in many of these individuals who start this. Decrease in seizure threshold is an important concern you should have, especially if there is family history of seizure disorder and past history of seizures. Be careful about prescription of bupropion, because it can further decrease the threshold of seizure. Now, we know there are other anti-craving strategies we can have. Some of the other important anti-craving strategy we can use is this has nothing to do with the dopamine. This is a different strategy we work with. We use a partial agonist. We use a partial agonist called Varenicline. Now, Varenicline is a partial agonist. By being a partial agonist, what does it do? It blocks the nicotinic receptors, but does not give the high. See, if there is a full agonist, it gives a high or a pleasure or a kick. So the brain wants to keep using the substance. This goes and blocks the nicotinic receptors. Because it's a partial agonist, it does not give that high, but blocks the receptors and kind of takes care of the craving and the withdrawal and helps the person to stop smoking and those things. That's typical of them. But so Varenicline is known to work on the alpha 4 beta 2 partial agonist. It's a alpha 4 beta 2 partial agonist. One of the problems you should be careful about is worsening of neuropsychiatric symptoms like depression symptoms and anxiety symptoms. There are some studies which says suicidal thoughts are sometimes known to worsen with these people. So be careful about it. In our patients, most of them don't want to take this medication, basically because they think it's too costly and they don't want to spend money on this. But of course, many times they end up spending money on nicotine. Earlier, as a young psychiatrist, I used to get very angry at these patients and wonder why would they be actually not spending money on treatment, whereas they're willing to spend money on alcohol or a substance of their choice. now I very much know over years one is we expect them to make irrational decisions because the dorsolateral prefrontal cortex is having its problems. The prefrontal cortex, we know, is important area for making decisions. If they could take all the right decisions, they would have not even got into substance use problems. So you need to realize there's no point in getting angry and upset with these clients. We need to say, I really understand that you're kind of, in fact, these days, I explain them, see, you had this money, instead of medicine, you were willing to spend this money on smoking. Can you see how this substance is hijacking your brain? And they seem to understand it better, and they seem to realize how they have become victim of the substance and are willing to work on. If you see, a lot of AA people will talk about being powerless. Now, when they talk about powerlessness, even neuroscientifically, we can also try to explain how powerlessness works, right? So when these circuits have hijacked, the decision-making cortical systems are not very efficient. The top-down is not working efficiently. You can't expect them to make healthy decisions. So we need to handhold them and work with them is what you need to understand. So when we work with tobacco cessation, we always have clients fixing a quit date, right? It is always recommended to make them fix a quit date within 2 weeks of the time they have met us, not beyond that. Try to ask them to make it a quit date. Like, for example, let's imagine today is 29th. So a good quit date would be 1st February. Another good quit date, it could be 14th February, which is Valentine's Day, and maybe they like a partner or they like their loved one, so they want to quit in for their reason. So like that, if you can help them to take a quit date, which is just around 2 weeks, is a decent time. And 2 weeks is also helpful because if you start off bupropion in about 2 weeks time, you know it's building up enough storage so that when they quit, the craving can be taken care. Varenicline also, you can do the same thing, where Varenicline, the molecule, the company which produces this, comes up with the day one what should be given. Their packets itself will explain how exactly it should be taken. It comes as a starter pack and those. So obviously with such designing, they also have to charge some amount of money for that. They do charge for it. And unfortunately, because of the cost, a lot of patients don't want to choose this molecule. But in the people who choose, we know it works pretty efficiently. So day one, day two, day three, you give only 0.5 mg in the morning. Day three, 4, 5, 6, 7, till the end of the first week, you give BD 0.5 mg dosage. Then the whole of second week, 1 mg BD dosage is given, and it is continued for at least 12 weeks or so. So that's exactly what is typically done in these people with Varenicline. And that's one of the other useful strategies. Now, briefly talking about alcohol, which is again something which I'm sure we all deal at different levels at different points of time. To keep simple, uh, there is going to be changes in glutamate because of alcohol. There is going to be changes in GABA. Now, alcohol basically increases the GABA and brings about an anxiolytic kind of an effect. And that is one of the reasons, if you see a lot of people with social anxiety end up self-medicating themselves with alcohol. Why? Because it keeps them calm. We try to give them benzodiazepines, we try to give them medications which work on the GABA receptors. They self-medicate themselves with alcohol, is what you need to understand. So GABA A receptors, GABA B receptors, both. Now GABA A is post-synaptic, and specifically the delta unit is known to work specifically in GABA A. Whereas when you're talking about the pre-synaptic, we have the GABA B receptors. We'll come to the importance of GABA B in a few minutes' time. Glutamate works in the pre-synaptic area, and please understand, we have spoken about glutamate in a few other lectures earlier, so I'll not stress about it here. We also need to understand alcohol seems to have some effect on the opioid neurons and the endocannabinoids also. Now, there are two important treatment strategies with alcohol: the anti-craving strategies and the aversive strategy or the deterrent strategy, right? What are the important aversive or a deterrent strategy? Answer is disulfiram. Very simple, we all know. When you're talking about anti-craving agents, there are many which are chosen by us as clinicians. Of course, the most well-known and most effective ones are acamprosate and naltrexone. Easy to remember, ANTSOB, 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 acamprosate, naltrexone, topiramate, SSRIs, ondansetron, and baclofen are important anti-craving drugs. Let me highlight a few important points in relation to that. For example, naltrexone is a good choice in our patients, especially in today's world, because a lot of our patients will openly tell you, doctor, don't ask me to quit alcohol. I cannot quit alcohol. You tell me anything else, we'll talk about it. So if you're sitting and telling, no, abstinence is the only rule we have to follow, it might not work with them. And unfortunately, we are demotivating them and sending them back home because they might not take further professional help too. If they want to be a social drinker or they want to be an occasional drinker and those things, it unfortunately is the decision they choose, and the pros and cons is something they need to be willing to deal with. But our job is to see what is the right kind of a medication we can choose for. So naltrexone is especially useful if they're binge drinking people, social drinking people who want to maintain social drinking. They're drinking very, very frequently, high amounts of alcohol, but want to get into kind of social drinking patterns. Think of naltrexone as a choice. If their family history says of alcohol use issues, early onset alcohol problems, very high craving levels, all those kind of people. And when they've anticipated drinking, when in the year do you actually anticipate a lot of people drinking? Tell me. The end of the year, right? 31st of December, which went just some time back. Now, a lot of them know they're going to drink on that day. So if they at least take, I mean, it might not work very efficiently, but if they're taking even few days of naltrexone just before that, the chances of the drinking higher amounts might come down. And again, these are all ways to help these clients to achieve their goals. Now, as a clinician, I might be wanting them to quit alcohol, but they might be coming with a different agenda. So always understand substance use is about them, and they need to see what is the goal they want to work for, and you need to aid them. Alcohol is pretty safe. Most of the times they tolerate well, but a lot of them don't take naltrexone because of the costs which get involved with it. But otherwise, if at all we see common side effects are gastrointestinal distress, liver function tests sometimes can be raised. Now, this liver function test can be raised because of the underlying alcohol use or because of the naltrexone. It's always recommended before you start naltrexone to get a liver function test as a baseline to know whether there is any dysfunctionality. And you need to avoid naltrexone in liver dysfunction, or even if you have to give naltrexone, maybe consider a much lower dosage. There is a theoretical possibility of naltrexone worsening dysphoria or depression symptoms, naltrexone worsening chronic pain. Now, I have not seen anybody coming up with chronic pain worsening with naltrexone, but it is reported, and it's something which you should look for. If your clients report about it, it's a good idea for you to work on it and take it off. Acamprosate, by that way, is a little different molecule. Now, naltrexone works on the opioid receptor blockade, whereas acamprosate is an NMDA antagonist and a GABAergic kind of a drug. It is a GABAergic kind of a drug and an NMDA antagonist. The moment I said GABAergic, you can realize that we use benzodiazepine, right? To handle withdrawal symptoms. So in some people, they can have protracted withdrawal. In some people, in those kind of people, where there's protracted withdrawal, chronic withdrawal symptoms, where you don't want to give a benzodiazepine, but you want to give some other drug, you need to think of acamprosate as a choice. Acamprosate is safe in hepatic impairment and medical conditions. And you know, a lot of alcohol patients will have comorbid medical conditions and hepatic impairment. And in those scenarios, acamprosate is a good choice for us to consider. It is also important for us to understand that it can be given with benzodiazepines when detox is happening. Late onset alcohol dependence syndrome, acamprosate is more preferred. People who are looking for abstinence, you can think of acamprosate. Acamprosate is safer in hepatic impairment, but it is something you should be careful about in renal impairment. In renal impairment, acamprosate is something which you should try to avoid because it is renally excreted. Now, the problem with acamprosate is, of course, the cost is high, so patients don't want to be motivated to take it. But the problem is, if they're less than 60 kgs, you need to give 4 tablets of acamprosate. And if they are more than 60 kgs, you have to give 6. Now, 6 tablets or 4 tablets makes them very demotivated, right? So that's one of the common problems I've seen. What patients do is they take 1 or 2, or they do all this kind of strategies, which many times makes the effectiveness of the medication come down. If they are willing to, so I always tell them, see, this is the medicine, this is the approximate cost, this is the medicine. See, naltrexone, the advantage is 1 tablet, but this is the cost. This is 4 tablets to 6 tablets, so this is the cost which will come to you. So when you explain them all the pros and cons, at least they know they're taking an informed decision. Otherwise, what happens is when you write a prescription, you are allowing them to take a decision when they reach home. And please understand, in substance use disorder, if you expect the clients and patients to take the right decision, I think it's a mistake as clinicians. We need to make it easy for them what's the best decision so that they stick to the decisions and work on their own health and take care. One of these strategies, which is very, very useful, is Baclofen. Again, now Baclofen has growing evidence to say it's working. A lot of clinicians have started prescribing Baclofen for anti-craving, especially with alcohol use. It's a GABA B agonist. 40 to 60 mg is the dosage, and it was known to reduce craving. An interesting point I can tell you is, before my psychiatry, I was working in neurology at Nimans as a resident. As a resident, when I used to work there under the professor, Dr. Satish Chandra, I used to see a lot of these patients with muscle spasms and all. He used to say, write 10 mg, 5 mg of Baclofen. And whenever we used to write 5, 10 mg, patients used to become drowsy. And my knowledge was, okay, Baclofen used as in spasms and those, and give 5 mg and 10 mg. More than that, patients can be drowsy. That's how I learned about Baclofen. Now, a few years later, when Baclofen was prescribed more for alcohol, I started prescribing patients just 5 mg and 10 mg, and we used to be worried because I have seen that the neurologists would be worried to prescribe because of the sedation and those. Later on, when I kind of saw colleagues and friends work in the addiction unit at Nimans, their prescriptions, and when I listened to their lectures, is when I realized Baclofen at 5 mg, 10 mg doesn't work. You need to be giving at a much higher dosage of 40 to 60 mg. So why I'm highlighting this is because you need to know each of these molecules can have its own dosages. Now, it's good to know where is the right therapeutic dosage. Otherwise, trying 10 medicines at half-hearted levels at small doses might not work. So we should, of course, we should see whether they tolerate it well, slowly escalate the dosage and all. But it's a good idea to know at what dosage, in which conditions will it work. So that's a good idea for you to learn. Topiramate is one of the medications, personally, is one of the go-to medications which has worked. Now, again, topiramate, if you see, is not an FDA-approved strategy and those, but one of the reasons a lot of my patients actually would choose to go to topiramate is because it's quite cost effective. And more importantly, it is just 1 tablet they can take and they seem to feel much better and not much of weight gain, and those quite well tolerated. Renal stones, kidney stones or renal stones are some issues. Cognitive issues has been quite noticed. I have seen in some of the patients whom we see, they kind of have memory lapses, word finding difficulties quite commonly. And many times when they take it in the night, we have seen sleep issues, dreams, weird dreams, and those things quite commonly happening. It has a possibility of worsening the psychosis in some people. So it's good to kind of look for it. And weight loss is one of the things which happen. Many of our patients, of course, if they are on the heavier side of the weight, they would prefer a medication which could cause a little bit of weight loss. So topiramate becomes one of the choices to think of. But please remember, the evidence for it is way much lesser compared to a Camprosate and naltrexone, which is supposed to be more like an FDA-approved kind of a drug where a lot of evidences are there for these reasons. Now, disulfiram, again, I'm sure is one of the oldest drugs we know, which is used for alcohol issues. I think if a patient is willing to take disulfiram, that's the best medication. Very clear, very simple, it works. And I can give you a real example of one of the clients whom we saw many years back. Now, this guy, we spoke to him, we motivated him. he had already been abstinent for about 2 weeks. So I said him, see, if you really want to quit, here is disulfiram, which is a good choice for you to think. Otherwise, we can put you on anti-craving. He said, no, I'm willing to take disulfiram. I am motivated. I don't want to get into alcohol at all. So we put him on disulfiram. 4-5 days later, at about 9 o'clock in the evening, he called me up and he said, sir, the drug works. I said, what do you mean? He said, I wanted to test and see whether the medicine really works or is it just a placebo you were given. So I tried to take little alcohol and see. I had nausea, vomiting. I kind of had a discomfort. So the drug really works. Now, I think you might have clients doing all these kind of things, despite your explanation, despite taking consent from them. So be careful. Always take a concern, motivate them enough, and don't give disulfiram. Obviously, a lot of times spouses, family members, relatives will come and ask, can we prescribe some medication which can be mixed in food and given and all? It doesn't work. It should not be done. And I think uh, it's good to use only in extremely motivated people. Earlier, even 1000 mg and all were tried. These days, people go 250 to 500 mg. It can be started anywhere between 12 to 24 hours after the last alcohol drink. And very important point to explain every person whom we put on disulfiram is telling them, don't stop the medicine abruptly. And if you stop the medicine thinking, okay, today is the December 31st, I want to drink alcohol, let me stop today, don't go and drink alcohol, because if you stop the medicine, still for next about 2 weeks or so, you might have disulfiram roaming around in your uh, body, which basically means the enzymes which have been irreversibly inhibited might still be in problem. So basically, the disulfiram ethanol reaction can happen for about 2 weeks, even after stoppage of disulfiram. It's good to tell, because if you don't tell this, patients' knowledge would say, okay, today I'm going for a party, let me have little alcohol, let me skip the medicine today. If they skip medicine one day, they still might have reaction, because it can remain for about up to 2 weeks. So that's something which is good to put knowledge into them before they get into trouble. That's an important point for us to know. Moving on to the third important chemical, what I thought is, in this chemical, I'll try to highlight some other interesting aspects, which is very good for us to do, kind of emphasize in this platform, because we are dealing with young budding psychiatrists here. Now, weed use is kind of quite rampant, right? We all know how rampant has become weed in today's world. Now, there are a lot of people who are already working on trying to legalize weed, and there are pros and cons for it. Let me not get into the debate. Basically, there are different species, the sativa, indica, and ruderalis. Now, different species have different components. Now, the two important components we are talking about is the THC, delta 9 tetrahydrocannabinol. Now, THC is the delta 9 tetrahydrocannabinol, and we also are talking about CBD, which is cannabidiol. These days, if you have your clients who are coming with their relatives from US, or if the clients have come back from US, they are going to ask you some question like, can I take CBD oil? Can I take CBD oil for this, CBD oil for that? It's kind of a big market out there today. A lot of people promote CBD oil for various conditions. So you will have a lot of clients coming and talking to you about CBD oil in days to come. Now, weed is not just about these two chemicals. It's a good idea for you to know a lot of other chemicals are linked with cannabis or the weed, and like cannabinol is there, cannabigerol is there, cannabichromine is there. Of course, you have the delta 9 tetrahydrocannabivarin. So these are all different molecules which are going to be there in weed. Now, the percentages of it could vary, especially the percentage of THC and CBD varying. It plays a role, because in simple terms, if you see the psychoactive component, people who take weed for its psychoactive component take it because of that delta 9 tetrahydrocannabinol. If THC is more, the psychoactive component is going to be high. Whereas cannabidiol is known to have its own protective effects. It is known to have its own protective effects. Now, you know, there is a bunch of lot of youngsters would come to your clinic and say, why cannabis is okay to take and why medical cannabis is there and those things. Please understand all of it mostly is in research in relation to cannabidiol, and it has nothing to do with the tetrahydrocannabinol many a times. Tetrahydrocannabinol have active psychoactive components, and it can lead to psychotic symptoms and other things in vulnerable population. Now, dronabinol and nabilone. Dronabinol and nabilone are synthetic cannabinoids, which are more like drugs which are marketed for various conditions. Medical cannabis, it's itself a lecture by itself. You can, I think, at some point of time, somebody will address on the topic. Now, when you're talking about endocannabinoids, I wanted to highlight an important point here. We have our own endocannabinoids and circuits and systems out there. There is CB1 receptor and CB2 receptor. These are the two main endocannabinoid receptors, the CB1 and the CB2. Interestingly, if you see this CB1, it is mainly in the brain, and CB2 is mainly in the immune system. CB2 is mainly sitting in the immune system, and whereas CB1 receptors, endocannabinoid receptors, is mostly in the brain. If you remember the first lecture of the psychopharmacology series, I did tell you endocannabinoids are one of the examples of retrograde neurotransmission. Retrograde, post-synaptic neuron to presynaptic, so retrograde transmission. So that's what we are talking about here also. This CB1 receptor is the most abundant G protein coupled receptor in the brain. If you think how important is endocannabinoid circuits, so this highlight will tell you how important is it. Now, what are the important endocannabinoids? Most of us will know when I'm talking about endocannabinoid, anandamide. Anandamide is one of the important endocannabinoids. The first endocannabinoid which was found is anandamide. The other endocannabinoid a lot of us will know is arachidonyl glycerol, 2AG, 2AG, 2-arachidonyl glycerol. But there are few other important ones also which have been found, which is nothing but 2-arachidonyl glycerol ether, which is also called as nolandin ether, or you have the N-arachidonyl dopamine, which is nothing but the NADA, or you also have the virodamine. Virodamine. These are all endocannabinoids which have been found as of now. There might be many more which might be coming up in due course of time. Now, if you look at this, in this endocannabinoids also, very importantly speaking, the anandamide is more specifically for the CB1 receptors. It works on the CB1 receptors, whereas the virodamine is more specifically working on the CB2 receptors, whereas the rest of the endocannabinoids have varied percentage of linking and affinity with the CB1 and CB2. CB1 specific is anandamide, CB2 specific is virodamine. Virodamine is CB2 specific. Lot of clinicians here who are listening to this will remember this drug called rimonabant, right? Rimonabant is a drug I'm sure some of us remember. It was promoted left, right, and center. And I remember when it came out, the amount of benefit we saw in all our patients who used to gain weight because of olanzapine and other antipsychotics. We used to prescribe this and they used to benefit a lot. But unfortunately, the speed at which it came, it also succeeded. It also went off the market because it worsened anxiety and depression. So this rimonabant is an antagonist of the CB1 receptors. By being an antagonist of CB1 receptors, it seems to change the metabolic syndrome, and it seems to change the weight gain and those things which is related to antipsychotics and all. It was a very promising drug, but unfortunately, it started causing so much of depression and so much of anxiety and other neuropsychiatric symptoms. It had to be ultimately kind of removed. So that's the challenge which happens with these drugs, but it has given us a highlight to say if some other drug can be found which can be effective, which is working on these receptors, maybe that day is not going to be far off and we might work well. Now, with all what I've suggested, it looks for all of us that there are only these medications which are very, very important strategies to work and help these individuals. Not necessarily there are important psychological interventions which can make a difference in substance use disorders. No prescription will work if we don't explain the patients why they actually need to take a particular molecule or a medication and how long and all those things. So just simple psychoeducation is the basic step we need to do. Brief interventions work. 5 A's and frames are two important strategies. 5 A's is nothing but it is useful in smoking, right? Ask, advise, assess, assist, and arrange. Now, when I put across this in some lectures, right? Some people come and say, "Sir, I think you've made a mistake in your slide. You put advise even before assess. It should be assess, then you should advise, right?" They'll say. Please understand, 5 A's strategy was developed for basically tobacco, nicotine smoking, and it's a very brief intervention strategy where you ask everyone whether they smoke, and if they say yes, you advise them to quit. You advise them to quit in a very stern, clear voice, telling they need to be quitting it. Now that advice has to come much before, and of course then you can assess and assist them and also arrange for a follow-up in due course of time. When you do a frames approach, you look for FRAMES, where you give a feedback, you tell it's their responsibility to take care, you give the right advice, you give menu of alternative options which are available, which they can take to take help. Be empathetic enough, and most importantly, you have to build their self-efficacy, and that's extremely important strategy in brief interventions. Craving management, simple 4Ds which work are these. Teach them some simple distraction strategies when they have craving. Teach them some deep breathing strategies when they have craving. Teach them some delaying strategies. A simple thing which I tell my patient is, okay, you have an impulse to go and smoke now. You do one thing, you tell to yourself, okay, it's about 9 o'clock now. Let me do one thing. Maybe at around 10 o'clock, I'll go. You delay it by an hour or so. So most of the times by 10, they might be busy with something else and they might be able to delay. So delaying is a simple strategy. Sometimes it works for some of these clients. Drinking fluids. I've seen a lot of patients coming up and telling us that drinking fluids helps them. Drinking some fresh juice or lime juice or something like which is kept ready in the fridge helps them whenever they have the craving. And I've seen especially a little bit of sugary content in it. We have seen a lot of people who stop smoking, start taking a lot of chocolates. Now, these calories, which are high, could have its own neuroscience, because if you see, craving is a brain energy consuming process. Maybe when you give a gush of calories to the brain, maybe because of the sugar in the fluids or because of the chocolates they take, maybe it kind of helps them in their craving. So we have seen a lot of these people being helped by drinking fluids and these strategy. So of course, they cannot drink alcohol if they are using alcohol. That's something which is also important for you to highlight. Now, motivational interfacing is a useful strategy. It's a seminar and lecture by itself. People do workshops for 3 days talking about motivational interviewing. I'm just going to tell it in 30 seconds. Simple principle for us to remember as a clinician is DARNC, D-A-R-N-C. What does that stand for? You work with increasing the person's desire to quit. You work with the person to increase the ability to quit. You work with the person to increase the reason and need for change. You constantly work with them and make them talk. And most importantly, your job is to elicit and promote change language. You constantly elicit and promote change language in your client and make them kind of work on their desires, abilities, reasons, and needs. That will kind of help you to make them make a positive change towards recovery. Other than that, most importantly, work with relapse, help people to kind of relapse prevention strategies, talk to them about the difference between a slip and a relapse, and ask them to take help much more early. Ask them to please give permission to come and meet you. Tell them, even by chance you end up smoking or drinking or using a substance or lapsing, please come and meet us at the earliest. Don't allow it to advance, because that has helped a lot of people to reach to us and take the right help. So just a few points of prevention. You need to understand, when you're talking about prevention, you can always ask yourself, what kind of prevention strategy can we work? Micro prevention strategies, working with the individual in specific, very small micro prevention. Meso prevention strategies, working with close-knit families or small groups of people and those things. Macro prevention strategies at a level of community and those. Like that, you can work with any other substances and those. So I think I've taken you in the journey right from simple neuroscience circuits to habit to various chemicals which can be used. I think we have kind of spoken about all these things. With this, I think I would like to kind of stop here. I'll just give a few minutes to see if anybody is asking some questions for which I think I have an answer. I'll kind of take it up here. We will meet next Friday with interesting special populations, special discussions on interesting presentations which can happen clinically and how we deal with it. That's something which we will catch up the next week. Any questions anybody has, please post it in the next few minutes so that we can address it. Is there any efficacious drug to make a patient leave cannabis? I think the drugs which work with tobacco, a lot of people who use cannabis mostly also are using nicotine. So a lot of drugs we use for nicotine cessation is some things we try with cannabis also. I think naltrexone specifically is known to work in a lot of people with varied varieties of craving and impulsive behaviors and high risk behaviors and those. So that's something we try many times in cannabis use. I hope we develop some molecules on cannabis specifically. I am not aware of any specific molecule telling this is useful only in cannabis use as such. I think we are done with it. Thank you very much. Have a great night. We'll catch up next Friday. Thank you very much.